Hello, MCHD. This is Jeff with Remick.
Hi.
Hi, how are you?
Good. How are you?
Good. If you just, I can see and hear you just fine. If you would just go ahead and remute your microphone on your end, we'll be all set.
Oh,
It's not the pod phone on the table. The microphone's probably coiled up in a cable underneath the TV.
oh, this jumble of mess down here?
Yep, just, someone did not take care of it correctly. There should be a button there, or you can use the mute button on the remote.
Oh.
Point it at the TV, and there's an orange button. There we go. Thank you. Okay, this is Jeff with Remick. Thank you for all that who are joining us today for the program today. MSU, you can go ahead and start when you're ready. We have all the sites that we know of connected, and so we'll leave it up to you to go ahead and do your program.
Thanks. Thank you for joining us today for Nursing Grand Rounds. My name is Victoria Lansing. I'm the Education Program Manager for Michigan Center for Rural Health, and will be facilitating today's program. This program is jointly provided by Michigan Center for Rural Health in cooperation with MSU College of Nursing. We provide nursing, continuing education, and social work education for today. Please remember to keep your mic muted until the Q&A component at the end of the presentation. And handouts are located on our website at www.mcrh.msu.edu. Click on the education link across the top and then scroll down and find today's date, March 2nd. And then there you will see the attendance form, the presentation, and your evaluation. Attendance forms need to be filled out by hand, and then don't forget to send in your attendance form via email, fax, or mail it back to our office, and then complete the evaluation online via SurveyMonkey. Certificates will not be sent out unless both the attendance form and evaluation have been completed. We are asking that you complete these forms and return them to our office within 2 weeks or by March 16th. Certificates will not be mailed out unless if we receive these forms, and then these certificates take usually 6 to 8 weeks to receive. The speaker and planning committee did not indicate that there is no conflict of interest for this program, and no commercial support is provided. At this time, I am pleased to present or introduce our presenter, Patrick Crane, who will be speaking on COPD management of the outpatient. What?
All right. Thanks for having me, everybody. Looking forward to talking today about COPD, just giving a little bit of an update and some review material. I know all of you are nurses and or social workers out there, so you've probably seen COPD on some level. Again, my name is Patrick Crane. I am a faculty member at the MSU College of Nursing. I teach both in our graduate and undergraduate programs, and I'm also a nurse practitioner at the Ingham County Jail. So I see a lot of rural health issues in my practice, and I was also an ER nurse in a formal life, so I have seen many of the patients who you encounter on a day-to-day basis. And again, I just like to thank you for having me, and I'll be happy to answer any questions you have at the end of the session. So as described, I have no conflict of interests at this point to disclose, so we'll go ahead and move on. So COPD is really all about obstruction, which is what the name implies. There's terms that are often used to describe separate diseases contained within the definition of COPD. I think in nursing school we've all been taught that COPD is a group of diseases, including emphysema, chronic bronchitis, refractory asthma, but really these definitions encompass different elements of what we call COPD rather than different diseases themselves. They reflect different pathophysiological changes that happen in COPD. And in the most recent GOLD report, which is, for lack of a better term, the gold standard of how we evaluate and manage COPD, they specifically did not include these terms in the definition. So this creates a real change philosophically and from a definition standpoint of what chronic obstructive pulmonary disease really is. So we can still use the terms emphysema and chronic bronchitis to describe what's going on physiologically, but it's those changes that, by the way, can often develop separately and evolve at different rates. That's really the symptoms and the changes that make up COPD. So this is the World Health Organization definition. And I want to focus on a couple things within the definition. This is this year's verbiage. So they call it a common, preventable, and treatable disease. And right away, that definition starts with three very key terms. So common. We are seeing more and more COPD in the world. In the US, I think it's easy to forget about this because our smoking rates, a behavior that we often associate with the development of COPD, have been decreasing. But actually in developing countries, smoking rates are going up, and they also have other risk factors, which we'll talk about a little bit later. Preventable is also another key term. So preventable implies that in most cases, we as nurses, we as healthcare providers, can provide early interventions, early screenings that can help keep away the development of this debilitating and often fatal disease process. So ways in which we go about working with patients in prevention, we'll talk about a little bit later, but we all have a really important role to play as nurses in helping reduce the disease burden in the United States. It's characterized by persistent airflow limitation. It's usually progressive, which means this disease gets worse over time, even with proper management. It's enhanced, or it's associated with enhanced chronic inflammatory response, so this is a disease of inflammation. And exacerbations, comorbidities contribute to all severity, to overall severity in individualized patients. So another important part of our role from the preventative standpoint and from the management standpoint is really about reducing the number of exacerbations. In fact, it's exacerbations in COPD which lead to the highest healthcare costs, the highest burdens of disease. The more exacerbations you have, the more you're going to be hospitalized, the more you're going to be in the emergency department, and the more you're going to be likely to develop other lower respiratory diseases such as pneumonia. So currently in the United States, we have about 15 million Americans living with COPD. That is an incredibly large number. What should be more shocking to you is that by most estimations in scientific literature, this number is low, significantly low. The number may be almost 30 million if we capture enough COPD patients early on. So screening is something we have not done very well in the US healthcare system, asking the right questions, providing the right testing. So something to pay attention to. 15 million sounds like a lot, but the reality is it might be even higher, and likely is. Lower lung disease is reported by the CDC as the third highest cause of death in the United States. Lower lung disease includes COPD. And in the US currently we're spending about $32 billion in direct costs for providing services to COPD patients. $20 billion in indirect costs. So indirect costs are things associated with lower quality of life. You can think about disability days. Those are the indirect costs associated with caring for COPD patients. And just to compare this globally, COPD is currently the 4th largest cause of death and projected to be the 3rd leading cause of death globally by 2020. So you're working in rural health. Michigan is largely a rural state, as many of you know. So some statistics from the state and how they compare nationally. So about 8% of adults in Michigan have been told that they have COPD by a healthcare provider. 6.8% of the patients, or of the people living with, or the population, are men. So a little bit lower than the national average. 9% are women. So when you look at those numbers, you come in the middle, you get about 8% of adults. The striking thing here in the state of Michigan is that more women are living with COPD than men. That has not been the trend nationally. There's a few reasons for these numbers that have been hypothesized, but none have really been demonstrated. Behaviors with smoking. So it used to be that smoking was a predominantly male behavior. That has shifted, and those numbers are now more equivalent. So even though we're seeing less overall smoking, we are seeing an evening of male and female smokers. There is some evidence that shows that females are actually more susceptible to the effects of tobacco smoke. So men may have some protective elements. The genetics and mechanisms for that aren't fully understood yet. So we may just be seeing some shifts in behaviors that have led to the shifts in the numbers, especially in Michigan. 43.7%, so you're pushing up towards half of all COPD patients in the state have reported their health as either poor or fair. So that is an overall perception of how well patients feel. So what that should be telling you is that half of all the people who have been diagnosed with COPD are not living the lives they want to live. This is a really, really important consideration for nursing, for social work, for all healthcare providers, really, because it is our role to help people respond to the burden of their disease. And if we know that they're reporting lower quality of life, that they're reporting fair health, it shows us that we need to intervene. While we may not be able to reverse the disease process, while we may be able to not completely prevent COPD, we can certainly work together to create interventions that can help these people live better lives, to be as productive as possible and to be as happy as possible. 24% of COPD patients have taken more than 14 mental health days in the past 30 days. So COPD is isolating. It is a disease process that causes people to feel isolated, depressed, withdrawn. And while I don't have the evidence to support this, my hypothesis is that you're seeing a lot of the same people who are taking those mental health days reporting having poor to fair health status. Almost 20% have reported hospitalization or ER visits within the past year. So again, that reflects back to the cost. I don't think you can find anybody around you who loves going to the hospital, who loves visiting the ER. So you can imagine the contribution that creates not only financially, but to other burdens as well. And over 50%, 54.8 reported lower quality of life due to COPD in the state of Michigan. So one of those changes that occurs with COPD that we used to use in the definition is chronic bronchitis. And the definition of chronic bronchitis really hasn't changed probably from the time any of us were in school. It's a chronic productive cough for 3 months. And when you think productive, this isn't necessarily purulent sputum. You're not seeing that dark green, yellow, we'll use crud, that seems to be a proper medical term. But this can be light, clear sputum, but the point of it is they are coughing up sputum, and it has to be productive. This needs to occur in 2 successive years. So you have the chronic productive cough for 3 months or greater, and you have that 3 months or greater period for 2 successive years. Other causes of this cough need to be ruled out. So whether it's an infective process like pneumonia, or bronchitis, or reactive airway disease, you name it, you need to rule out all their causes before you call this chronic bronchitis. So that may be the first clue that a patient has to having COPD. It may be the first clue you encounter. So you have a patient who comes into your workplace, you sit them down, they're there for maybe a routine checkup, and they bring up something to the effect of, remember last year when we met and I told you I was having this cough and it went away, I was feeling better? Well, it's back, and I've had it for the last couple months. And then you should really try to dig down deeper and say, okay, tell me when this started. How long has it lasted? What do your other symptoms look like? Because you may be the first point of contact to really screening that this person may be developing COPD or has developed COPD, is probably the more accurate terminology. The other process that goes along with COPD that you see a lot probably in your healthcare settings is emphysema. So this is really the structural changes that happen. Chronic bronchitis talks about the inflammation, it talks about the increased sputum production, but emphysema is really implying the destruction of the air spaces within the lungs. So this is losing elasticity. This is the chronic narrowing of the airways. This is destruction of the alveoli, fibrosis. These are the elements that go with the physiologic changes. The other important note is that these are permanent changes. So even if you stop the risky behaviors, you work with your patients to make sure they're getting non-pharmacological and pharmacological interventions, these changes are still not going to go away. You can help, hopefully, to reduce their rate of exacerbations. You can help to slow down the progression, but those changes are going to stay. So I don't know if you can really see this picture very well. You also have access to the slides. But this is a pretty good example of what normal healthy lungs and air spaces look like at the top compared with changes that occur with COPD. So in the picture below, you can see that the alveoli, they tend to become larger. Some of the walls between the alveoli start to break down. They lose the ability to exchange gas from the alveolar space back into the blood supply. You can see that the airways actually become narrowed, that the smooth muscle around them starts to break down a little bit. And this doesn't really illustrate very well just because of the color palette the artist chose, but you can see how the mucus starts to plug up those already narrowed airways. You can sort of make the equivalent analogy to a person with cardiovascular disease with the narrowing of the arteries. So you lose elasticity of the arteries, and then with the plaque buildup, the less tolerance there is for a reduce in blood flow. So it's hard to push out air into the or from the lungs when you have these narrowed air spaces, you have mucus blocking the way. You can, and then once you do get air down there, you can't exchange the air very well. So risk factors, you may be familiar with most of these. Some of these things are what we've always been taught. It's what we've always learned. It's what we've seen on the back of packs of cigarettes from the Surgeon General. But some things are becoming more evident as we discover more about genetics and genomics. So still in the US, cigarette smoking is number one, the biggest risk factor for developing COPD. 80% of COPD patients have a history of cigarette smoking. So that is a pretty eye-opening statistic. Interestingly enough, though, only 50% of people who have smoked will develop COPD in their lifetime. So if you have COPD, chances are you've smoked, but if you smoke, you have a 50-50 shot of developing COPD. Still not a roll of the dice I would recommend changing. So from a preventative standpoint and from reducing the risk of exacerbations, this is an area nurses should really focus on. This is something I see a lot in my practice in correctional facilities. I know in rural health, we tend to see higher rates of cigarette smoking. I try to focus in on most of my patients some type of smoking cessation. There is pretty good evidence out there that even 3 minutes of smoking cessation counseling that's directed and tailored to your patient can be effective. It's also, I don't know if any of you out there are working with young adults, with adolescents. This, again, is one area we should really focus on for prevention. We know that young adults and adolescents don't have a developed prefrontal cortex. They're not real good at projecting the future. I know I see this in my niece every day. She's a case study. Some of you have kids. But talking about smoking is really important, and encouraging their parents to talk about smoking and the risks associated with that as well. Genetics play a huge role in COPD. We don't quite fully understand what genetics protect smokers from developing COPD. But we do know that there is one genetic disorder which will lead to COPD regardless of smoking or exposure history, and that's alpha-1 antitrypsin deficiency. This is a genetic disorder which there is not a significant protease inhibitor produced in the body, so the proteases then go on to cause damage within the lungs. So if you see somebody in your clinic, particularly a younger person, less than 40 years of age, who has developed shortness of breath, they're getting the chronic bronchitis, the symptoms of emphysema, talk with your providers, or if you are a provider, looking at serum testing for alpha-1 antitrypsin is really important to determine the cause, especially if you can't find any other exposures like occupational exposure, secondhand smokers at home, biomass fuel use. Low socioeconomic status has been linked to the development of COPD. There may be many reasons for that. We know that people of lower socioeconomic status do smoke more, but even when you adjust for smoking, they do tend to have a higher rate. Now that can be because of their occupational history. It can be because perhaps they are using more biomass fuels. So biomass fuels you see a lot in developing countries, but you also see in rural areas in the US. These are things like burning wood to cook in the kitchen. A lot of developing countries use animal dung as fuel. This is a major contributor to the development of COPD. So you can imagine you're standing around that fire all day inhaling organic compounds, all the byproducts of burning wood. You do that over a longer period of time, you're inhaling particulate matter, you're inhaling those byproducts, and you do develop COPD. Age, we know that as you age, your risk goes up. The mechanisms are not quite known yet. There is some theory that age reflects the accumulation of inhaled particulate matter of irritants over time, or it could also be that the development of COPD changes may be a part of normal aging processes, and there may be a genetic component as well. So scientists have not really figured out the exact linkage there, but there's certainly a strong correlation between age. We usually start to see the development in this country occur after age 40. Environmental exposure, air quality is very important. Again, it's inhaled particulate matter, it's irritants. You see chronic irritation over time. Tuberculosis, people who've had a history of TB. It's an infectious process, causes inflammation, causes structural changes in the lungs. There's a definite linkage between people who have a past history of TB as well. In my practice at the jail, I see a high proportion of TB exposed individuals. If you're working in rural areas, particularly where there is a lot of immigration, a lot of immigrant population, this should be something you're paying attention to as well. Asthma is something we don't often think about contributing to COPD. Asthmatics have a 12-fold higher risk of developing COPD than somebody who does not have asthma. So if you're thinking about chronic inflammation, the role that oxidative stress might play in developing COPD, having your body assaulted consistently with inflamed lungs certainly links up to that risk. So what should you do when you're in clinic? What are some things you should focus on? I think one of the most important things we do, other than sit down with our patients and talk to them and help them overcome barriers to health, is take a good health history. You can learn a lot by just taking the time to go through some very specific things. The easiest thing to do, ask them if they've been experiencing shortness of breath. This is a pretty non-specific symptom. You have to look obviously at other causes like cardiovascular issues, but this may be one of the first symptoms that, again, tells you the patient's experiencing COPD. So they tell you that they've been breathless, and then you ask them if they've had a cough. And they say, yeah, and it's been going on for 3 months. And you go, aha. But remember, shortness of breath can be other things as well. So you'll still have to pair this with a good physical exam. Breathlessness is also often a symptom that develops after somebody hits their 60s. So maybe as early as the 40s, but by their 60s, they will really start to feel more shortness of breath, especially when doing routine things around the house that they've been accustomed to doing without that exercise intolerance. So we talked about asking about a cough. Ask about exposures. Cigarette exposure, that's one thing we routinely screen for. It's on all EHRs. It's linked to meaningful use. It's something we've had drilled in our heads pretty well from the minute we became nurses. But other things to think about. What kind of work do you do? If they work in places where you suspect there may be exposures to smoke, particulate matter, chemicals, ask them if they wear a respirator. Ask them if they wear masks. So really take the time to focus in on the type of work they do, what possible airborne exposures they may have. Have they had frequent respiratory infections? Have they been treated for bronchitis or pneumonia often in their lives? History of allergies. Allergies are often linked to other respiratory inflammation. Musculoskeletal disorders, especially if they're coming to you late in their disease process. COPD is associated with osteoporosis. It's related to anemias. It's related to weight loss. So you'll see a lot of deconditioning there. So if they've had a lot of fractures, that may tell you that they have osteoporosis. But if you're starting to see that paired with breathlessness, etc., you may be onto something else there. So physical exam, you may see the whole gamut of symptoms. You may see some of these, you may see all of these. The hallmark symptom that we always can tell when we're walking around the mall, or particularly I notice this when I'm at the pool in the summer, you can point out the COPD patients. They have the barrel chest. When you look at them from the side and you look at them from the front, their AP to transverse diameter is exactly the same. It's 1-to-1. They're thin or they're obese. We've often been taught that thin people reflect COPD patients. They're often malnourished, but guess what happens when you're breathless? You sit around. You're sedentary. So especially in the United States, we are starting to see more and more patients who are obese living with COPD. So they don't quite match that classic picture that we have been shown up on PowerPoints for and in textbooks for our entire life. Accessory muscle use. See how hard they are working to breathe. Often COPD patients will take on that classic tripod position. So you sit them down onto the exam table, or you sit them down onto the hospital, sit them up on the hospital bed, and they're braced up against the table. They're leaning over, trying to help their diaphragm, because it's been so flattened by the barrel chest, to push out that trapped air. They're often shorter of breath when they're lying down. So you have orthopnea. Again, this can be something you see in conditions such as congestive heart failure, but often COPD patients have a hard time breathing when lying down because they cannot get rid of that trapped air within their lungs. Pursed lip breathing, pretty classic. Clubbing in COPD, though clubbing doesn't always happen, clubbing actually is a pretty rare finding on physical assessment. Prolonged expiration, remember, they have trapped air. It's going to take longer for that air to get out. So you'll see the pursed lip breathing, and you'll see a short inhalation, long exhalation. And a later stage, which you'll see when a patient becomes hypoxic, is mental status changes. This may be a symptom of chronic COPD, but you'll start to see the confusion. You'll start to hear family talk about grandma, grandpa, mom, or dad just not being as sharp as they used to be. The other mental status that you see a lot is anxiety. Being short of breath produces anxiety. It is one of the focuses of palliative care, whether you're coming at it from a social work standpoint or from a nursing standpoint. To help patients cope with the anxiety of shortness of breath is a really key intervention to helping them improve the quality of life. Other testing you can do, one of the cheapest, most effective things involving technology is getting a pulse ox on these patients. You can buy a pulse oximeter on Amazon if your clinic is strapped for cash for $23 to $60, and you can spend thousands if you want to. But they're accurate, they're fast, they mimic what you would actually see on a blood gas very closely. The standard for if a patient needs oxygen or not, and it's what qualifies them for oxygen with most insurance, is an SpO2 of less than 88% on room air. But you can also use pulse oximetry for other things. You can see exercise tolerance. You can walk them for 6 minutes, see if their SpO2 dips, see if they're maintaining an adequate oxygenation level. You just have to be careful of a few things. Patients with carbon monoxide poisoning, pulse oximeters are not accurate. They can't tell the difference between carbon monoxide that's latched onto a hemoglobin molecule and an oxygen molecule. So if you're working in an urgent care setting or an emergency setting where you think you might have a patient who has COPD, but it's really carbon monoxide poisoning, this is a really important thing to screen for because your SpO2 will essentially be useless. You know, the other thing is it's non-invasive. Spirometry, however, is the major standard that we go by in order to diagnose COPD, but also determine progression of COPD. Forced expiratory volume, FEV1, that's one of the major components used in diagnosis and progression, and that's what your spirometer will tell you, one of the values your spirometer will tell you. In FEV1, you can think of, if you haven't focused on these things for a long time, since nursing school maybe, is it's the amount of air you can expire in 1 second. So you tell your patient to take a deep breath, and you tell them to let out as much air from their lungs in one quick puff. That's your FEV1. And then the other thing you look for is the forced volume, expiratory volume. So that's the total amount of air you can expel from your lungs. And when you're diagnosing COPD, you actually attach them to the spirometer. You'll do pre and post bronchodilator testing. And if after doing a short-acting bronchodilator, if their FEV1 to FVC volume is less than 0.7, that's the diagnosis for COPD. But the important thing is you have to do it after bronchodilation, because you're actually looking at the best case their lungs can do, if that makes any sense. So you're going to get those bronchodilators, you're going to open them up, open up those air spaces, and then if you see a change, you know that those are reversible changes, and that bronchodilator therapy is also going to be something that's important for them as well. I don't expect you to memorize these. These go way beyond the scope of today. You can take spirometry courses to learn about this, but this is an example of what the computer will actually print out. The one on the left is normal, and then the one on the far right, these are changes you'll expect to see with obstruction, but you can see it doesn't exactly follow the normal curvature. Other tests you can do, 6-minute walking test. You can do this in the clinic. Some of you may not have a course measured out, but I would encourage you to measure out a hallway, see how long it is, so you can have a consistent measurement of how far this patient can walk in 6 minutes. Usually, in most hospital settings, they'll just have tape on the floor. Clinic, you may have a little course that goes around the clinic based on how big it is. But just make sure that they're walking it in measured increments so that you can document, see what their tolerance is. Other interventions, again, critical for nurses. Check on immunization status. Influenza vaccines can reduce mortality in COPD patients. It is a really important immunization for these patients to obtain. I know we are constantly having to be vigilant on vaccination. We are fighting an uphill battle in some populations in this state. We are seeing decreased rates of vaccination in the state of Michigan and nationally, numbers that we are not too proud of. So when I say encourage vaccines in your population, I mean really encourage vaccines. Give them data, tell them about the risks. Anybody with respiratory disease, be it COPD, asthmatics, they should really be getting immunized for seasonal influenza. Pneumococcal vaccine, the evidence is a little less clear on the benefits for COPD patients of pneumococcal prevention, but it is still recommended for all patients greater than 65 years old. So that's for all patients, not just COPD patients. So if you are seeing older adults, certainly make sure you're recommending those pneumococcal vaccinations. The other things we do to help people manage is medications. So you'll be doing this in tandem with the healthcare provider in your clinic. But the big ones I'll go through real quickly are bronchodilators. So you have your short-acting, albuterol being the most common, Xopenex, and then you have your long-acting bronchodilators. So formoterol, salmeterol, those are the two big ones. Inhaled corticosteroids, those are the other major inhaled components. So it's very rare that you will have an inhaled corticosteroid alone. Usually, inhaled corticosteroids are packaged with a bronchodilator, so you have a dual action medication. Bronchodilators alone are fine if you have a patient who does not have a severe case of COPD, but when you pair them for moderate to severe COPD, when you pair them with an inhaled corticosteroid, It decreases mortality, it decreases exacerbations, it helps them control the progression of their disease. And so this is why most of the patients you will see in your clinic will be on both. Antimuscarinic agents, Atrovent is the big one that we see out there. Atrovent's 2 puffs. The problem with Atrovent is that you have to take it anywhere from 4 to 12 times per day. So there can be quite a range on Atrovent. You can't use it for people with glaucoma, and you can't use it for people with urinary retention. So be really, really careful if you have some of those people with enlarged prostates, not inhaled prostates, that if you notice that on your medication list, flag that, talk about that with your provider, make sure it's appropriate for that medication. Spiriva is 2 puffs once daily, so that's a long-acting antimuscarinic agent, a little bit easier for most patients than having to do puffs 4 to 12 times a day. Antimuscarinic agents are a great addition to COPD therapy. They reduce the frequency of exacerbations, and there's also good evidence that shows that it decreases the rate of hospitalization. So you may see these being used more and more in your settings. There's actually recommendations that we have the moderate to severe folks on triple therapy, meaning inhaled bronchodilator, inhaled corticosteroid, inhaled antimuscarinic agents. So there are medications out there that are emerging on the market in all of these categories. So you have to be really mindful, especially in rural areas, that you're not prescribing the newest, hottest thing because they're going to be expensive. You may have to make sure that these patients are working with social work or case management to make sure that they're getting the lowest cost options. And that may mean having multiple inhalers. So just be aware of that. So it's going to take more vigilance on your end to really make sure you're doing good teaching, making sure the family knows which inhalers are for what, which ones are dosed when, and, which I'll get to in a second, how to use each of these inhalation devices. Because some may be meter dose inhalers, some may be powdered capsules, some may be Respimat. So we have a lot of learning ourselves to do as nurses a lot of the times for how to use all of these devices that come out on the market. But our patients really need to know how to use them, because there is good science that shows often when medications are not effective for people with COPD, it's because they're not using the inhaled devices properly. So they're not getting the dose of medication they're getting. So if somebody comes to your office and says, this medication isn't working, the first thing should be, well, let's talk about how to use it and how you're using it. Because it could be that all the medication's getting deposited into their mouth and not into their lungs or their airways. Inhaled corticosteroids, usually used in conjunction with long-acting bronchodilators for moderate to severe COPD. Side effects, however, are the oral yeast infections, thrush. So you can also get a lot of vocal changes, hoarse voice, easy bruising with the corticosteroids. So I always tell nurses, and I always tell my patients, after you use that inhaled steroid, make sure you're rinsing out your mouth. And not just rinsing out your mouth, spitting out what you've rinsed. Because if you swallow it, you're just going to move the yeast to the back of the throat, and then you've got a really painful, nasty infection to deal with. Proper inhaler use is key. So do make sure that you're taking the time when you're dispensing a new medication, that you go into that room, you sit down with your patient, you demonstrate how to use that inhaler. Let them know if it's an inhaler that needs to be primed. Some medications like the Respimat or the discus devices need to be primed if it's first use or if they haven't been used for a certain amount of time. So making sure that device is ready to deliver medication. Patients are often concerned, well, if I prime my device, that's doses of medication that I can't take. And so, for example, the Respimat inhaler, it's important to let them know that they have figured the priming into the number of doses in the bottle. So they're not wasting medication. But in rural areas where patients have very limited resources, this is often a concern. So let them know also that if they don't prime it, the medication that they perceive as losing isn't going to be delivered anyway, because that device isn't ready to deliver medication. Use spacers when you can. I'm a big proponent of spacers. These are often something that providers forget to write for. They provide one more step in ensuring that the medication is actually inhaled rather than delivered to the mouth. It is very hard for people to coordinate the inhalation with the puff of their albuterol inhaler, for example. So the spacer traps the medication in an aerosolized form so that when they are ready to inhale, they can inhale on that spaced unit. So here's just some of the devices. I've put these on the PowerPoint. I won't go through all the videos, but these links up here are actually links to Department of Veterans Affairs videos that they have put together for patients to learn how to use their devices. Put these in your back pocket. I've used these with my patients before. When I was charting on the EHR in the room, I've opened up a browser, clicked on this video, showed them how to use the device. I have a little bit of a luxury because my patients are housed in my facility, even though they're outpatient, so I can pull them back up if they're having problems. But a lot of you, your patients are going to be living miles, hundreds of miles away, and you're not going to see them till their next visit. So give these videos to them. They're very good. They're public domain because they're from a government office, so use them. There's new devices coming out all the time. Some of them are very tricky, very difficult to use, and these videos are 2 minutes to 4 minutes each, so they really do a very nice job of showing you how those work. If any of the links are broken, feel free to email me, and I can try to send you the correct link. If the inhalers come in a multiple of devices, just make sure you're working with your patient provider to use the one that's easiest for them to use. This may come down to cost as well. Which one can they most afford? It may come down to coordination. It may come down to how many hands does it take to load this device. So just make sure that you're paying attention to that because, as you know from your experience, not all inhalers are made the same. And then every time you see these patients at follow-up, make sure you're checking how they're using them. You may see that despite your best efforts, they may have forgot key steps in the process. And reinforce the proper use, reinforce that this is how medication is best delivered, etc. Non-pharmacological interventions, always my favorite as a nurse. Avoid advice giving for the management of their COPD. Better work with them. Ask what they prefer. Encourage good health promoting behaviors. But advice giving where it's just you doing all the talking is rarely effective. We all have those friends, and think about how well we listen to them. Rather, it should be a two-way conversation. Develop a plan to discuss exercise. Exercise does not have to be rigorous physical exercise, but exercise is a very important part of pulmonary rehabilitation. So any care plan should involve physical activity to the extent that they can tolerate. Medication support, medication education, keep your patient's preferences in mind, and encourage your patients to monitor and manage their symptoms. Empowering patients to manage their symptoms when they start to notice changes, when they start to notice, say, the increase in sputum or a worsening cough, can often save them a trip to your office or to the emergency department. So you want to give them plans that are in plain language, that are easy to understand, that are easy to follow. For example, when you experience this symptom, this is the inhaler you should take. If you feel short of breath, here is who you should call. And so be available to, if you have a patient who calls and needs to speak with a nurse, be sure that you're available to speak with them also, because it may save them a visit. Energy conservation for people who are very short of breath, who have very bad COPD. This is really manipulation of their physical environment. Florence Nightingale would be proud. So maybe it is where their bed is relative to their bathroom. Maybe it's having assistive devices nearby to grab things off the floor, because stooping over can cause tremendous shortness of breath. So it's really about the home environment. Oh.
That's weird.
I've been cut off. The Oscars have started playing the music.
Yeah.
It automatically starts recalling again.
Welcome to the Michigan Center for Rural
It's
Health
never happened
Grand
before.
Round
That's
Series.
never happened before. Okay.
Glad I could be the first. Did we lose all sites?
I hope not.
Oh, we're back. Sorry about that. I was talking too much, I guess. Recognizing when exacerbations occur, having an action plan, stress management. Remember, we talked about anxiety. These are really important things, and these are good interdisciplinary activities to work with all disciplines that you have access to. Smoking cessation, we've already talked about. Many of you have education on smoking cessation. Let's put those slides back up. You don't care about watching me, I'm sure. Work with your providers to consider nicotine replacement. It does work much better, the evidence has shown, than just quitting cold turkey. Motivational interviewing. The other thing is getting patients set up for pulmonary rehabilitation, those who qualify. This is an interdisciplinary approach that uses nursing, social services, mental health individuals, dietitians, respiratory therapists, in creating multi-pronged approaches to improving lung function. It is the most effective method of reducing shortness of breath and improving health status in COPD patients. So do not forget about this resource. We talked about physical activity. The one problem with physical activity is the research does not agree on the type of activity, the amount, the duration. So that's still pretty unknown. So my philosophy is any physical activity is good physical activity so long as the patient tolerates it. It's not making them so short of breath that they're having increased heart rate beyond a therapeutic threshold, etc. So encourage your patients to do as much as they can. Palliative type care for decreasing breathlessness, O2. Opioids have been used in late cases. Again, with the opioid crisis, you need to work with your provider to be very careful, very cognizant of when it is an appropriate intervention. It is certainly not the intervention of first or even second choice. So be very mindful of that. But it has been shown to reduce the anxieties produced by breathlessness. Non-pharmacologic things to decrease breathlessness, things as simple as fans blowing in the face, can help improve the sensation of breathlessness. Pulmonary rehabilitation we talked about. Losing weight, so nutritional status. Eating smaller meals helps take the pressure off the diaphragm, helps patients breathe easier, smaller, more frequent meals. People with COPD have very complex psychosocial issues, anxiety, isolation, depressant. Oddly enough, the use of antidepressants in these patient populations has been pretty inconclusive in the literature. So it's certainly something you want to consider, but it's nothing that is certainly a magic bullet, and they rarely are in any other mental health issue anyway. So it's important that you are working with social work with mental health providers in order to assure that these psychosocial needs are being met in other ways. Mindfulness, yoga, relaxation all have their benefits as well. Just real quickly, because I know we're running out of time, and I want to give you a chance to ask some questions. Exacerbations are really marked by increased mucus production, increased gas trapping, and this is where you get the worsening shortness of breath, you get the thick, purulent sputum, and you get the increase in the coughing and the wheezing. Triggers tend to be infectious. Viral infections are our biggest culprit, and the biggest virus that contributes to exacerbations is the common cold. So unfortunately, it's something we all have to deal with. It's something people are exposed to no matter where they're at, no matter what population you're dealing with. Bacterial infections can also trigger exacerbations, and certain environmental exposures like tobacco smoke, industrial sites, they can set people into an exacerbation as well. These are just the classifications. I'll let you review those. But mild exacerbations, you can usually get away with just using their bronchodilator. Moderate, they typically have to have steroids and sometimes antibiotics introduced. And then in severe, these are your hospitalized patients that may go into respiratory failure and will need extra support, including ventilation and some other issues. Things you can do in the office and what they can do at home: position them upright. When you're examining your patients, lean them over a table, have a surface for them to lean on if that helps them breathe. Teach that deep diaphragmatic breathing. Staying hydrated, something we don't often remember to tell our patients. As long as they don't have any fluid restrictions, 2.5 liters a day is enough to help keep those secretions clear, to help things move along. Humidified air, helping them develop strategies to reduce anxiety. And we already talked about reducing the intake of large meals. We talked about environmental considerations, so we've already gone over that. And I would like to give you some time to answer any questions. So thanks for listening to me ramble on. I hope this has been a good overview.
Okay, so we'll now open the lines for questions. Please state your site name first and then ask your question. Are there any questions or comments?
Do you have an activity code for this session?
No, we don't.
Thank you.
Are there any other questions or comments?
I think I've put them all to sleep.
No. At one point you were saying that Atrovent do not use on. I didn't catch the rest of that.
Oh, you didn't catch that? Oh, those, so all of your muscarinics, you have to be careful that you don't use them with people. It's all those anticholinergic things. So people who have urinary retention, for example, you can actually send them into an acute exacerbation of urinary retention. So just be mindful of that. Glaucoma patients, that's a no-no for them as well. So just keep that in mind when you're looking at those antimuscarinic drugs.
Hi, this is Michelle from the Area Agency on Aging.
Yes.
We have a question about weight loss and COPD. We've
Yes.
seen some of our folks